We now move on to part 3 of our symposium on oral cancer and precancer, and in this section we're going to have a look at the natural history and pathology of oral precursor lesions. The progress by which you get from normal oral mucosa to carcinoma is complicated. In some ways it's simply put in this diagram here, although this presents the pathway as a one-way street, and that one will inevitably lead to another, which is perhaps not entirely accurate. Generally speaking, you will get changes in the mucosa, which might well give you a white lesion, a keratotic lesion, and then there'll be other changes which will occur within that epithelium, which we call dysplasia, which we're going to talk about in some detail. And then once the dysplasia stage has been progressed through, the start of invasion will come, and you get a carcinoma. So these precursor lesions have gone by many names over the years. Sometimes they've been referred to as pre-malignant lesions and so on, but the current term which is used is a potentially malignant oral disorder. And these are clinical presentations, so they are clinically evident lesions that carry a risk of cancer development in the oral cavity, which is higher than for normal oral mucosa. And so there are a couple of predefined precursor lesions, which is what I'm largely going to talk about in this section, and then some other general systemic diseases which increases the risk. So the two lesions which are relevant to this are leukoplakia and erythroplakia. Now, as far as the words are concerned, they are relatively straightforward because leuko is white and plakia is a plaque, and similarly erythro is red and plakia, patch or a plaque. But there is a more complicated definition for both of these. So the WHO have standard definitions. For leukoplakia, it is a white patch, which you would expect from the name, that cannot be rubbed off and cannot be characterized clinically or histologically as any other disease. So of course you will understand from that that in order to come to a final diagnosis of leukoplakia, you actually need to have had the lesion biopsied and the definitive diagnosis arrived at. Now, there are many different influences in the oral cavity, as we saw in the previous lecture on etiology, but the only thing you're allowed to have associated with the development of a leukoplakia is tobacco usage. So if it's got candida or anything like that in it, well then it's very difficult to make that. And similarly, lesions like lichen planus, which we're going to talk a little bit about in the next section. Now, what about the epidemiology? Now, when we looked at the cancer right the way back at the beginning, we saw there were good cancer registration schemes. But for leukoplakia, these precursor lesions, there's not. Some countries, for example in Scandinavia, have been very good at this. In the UK, we're not so good. And then when you have a look at the literature, you'll find that most of the studies which are presented on precancerous lesions or potentially malignant oral lesions have looked at leukoplakia. So there is actually quite a lot of literature out there. And as you can imagine, dependent upon the population that they're drawn from, whether they are a big population, a small population, whether they are a community population or a hospital population, the range of prevalence varies quite markedly, as you can see. That having been said, there have been some large meta-analyses done of this data, which shows that it's probably somewhere in the region of 2 to 3% of the population will have leukoplakia. And that's from worldwide data, as you can see in the first reference, and secondly from UK data in the second reference. So what do these lesions look like? Well, there are two main terms that we use along with the term leukoplakia, and these are homogeneous and non-homogeneous. And these refer to the clinical characteristics of the lesion. So if you have, as you can see in the picture here, a homogeneous leukoplakia, you can see that it is flat and plaque-like and pretty much uniformly white. You don't have to have a completely regular outline to it, but generally these are pretty uniform lesions. And we are going to talk a bit more about the histology later, but you can see in the histological image below that this is a lesion which has got a large, thick layer of keratin on the surface. That's the brighter red-coloured material on the surface. And other than that, the epithelium is looking relatively normal. Here is another lesion which is obviously much more extensive. It's in the floor of mouth. It is extending from the midline, from the frenum, and almost really as far as you can see round on the left side of the floor of mouth. It has a little bit of an irregular outline to it, but it is uniform, it is largely flat, and there is no significant variation in the coloration of it, although it's perhaps a little more translucent towards the anterior part. Here's another lesion, in this case on the lateral border of the tongue, and it's extending to the ventral surface of the tongue. This, as you can imagine, we'll perhaps discuss some cases in other circumstances, but you can see that this patient obviously is dentate, has a large restored dentition, and so there is going to be a differential diagnosis which needs to be considered here. If these restorations are rough and there may well be ongoing trauma, that may well need to be taken into account. But in this case, this again is a fairly uniform white patch. It's a little irregular in its outline, but generally it is uniform and there's no significant variation in the colour of it, even though it is relatively large. On the other hand, non-homogeneous leukoplakia present with a wide variety of different appearances. And so that difference can be either in the colour. Generally speaking, we're looking at the addition of red areas into the lesion, or texture. And that's difficult to gain from a photograph. You really get the texture part of that from clinical examination. A lot of different terms are used in this context. They might be speckled, or exophytic nodular lesions, or verruciform. That's almost a bit like verrucous. So they're going to have long kind of spires of thick tissue on the surface of it. And we'll have a look a bit more at verrucous carcinoma later on in one of the other sections. You can see the picture here, shows a lesion on the buccal mucosa. And in this case, although it is irregularly outlined, it is not uniform in its appearance, particularly in terms of colour. And you can see that this has some particularly red patches scattered throughout it. And generally speaking, you will find that the histology of these tends to be more concerning, and you will find dysplasia more commonly in lesions which are non-homogeneous, but we'll talk a lot more about that later. So here's another clinical lesion. Again, we're on the lateral border of the tongue and it's extending onto the ventral surface of the tongue. Towards the top part, it is predominantly white. There is some variation. It looks as if perhaps the area in the center might be a little thicker. But as it extends down onto the ventral surface of the tongue, in this case, you can see the development of red areas. So this is non-homogeneous. It is a mixed red and white lesion. This is a classic picture which has come from one of the WHO collections of these lesions, and this is where the term speckled may well be used. It is predominantly a red lesion, but has these dots of whiteness, which would histologically relate to keratosis, scattered over the lesion. Some of these lesions, which are mixed lesions, can be very extensive. And here again, we're on the lateral border of tongue extending onto the ventral surface of the tongue. And you can see that towards the anterior superior part of the lesion, it is thick. It looks as if you were to feel that, it would have a good depth to it and you could feel the lesion. Whereas in other areas, it's really quite thin. And scattered throughout it are these red areas, particularly heading towards the posterior part of the lesion. Assessing this type of lesion in the floor of mouth can be really very challenging. Many of the patients who present with lesions do tend to be older, and the older patients there tends to be that atrophy of the oral mucosa, particularly evident in the floor of mouth, which can make assessment difficult. It can become very translucent and be very challenging to see where the white patches are. But in this case, there is a generalized milky whiteness extending across quite a large part of the floor of mouth, and then there's a kind of ruffled up or corrugated part towards the front just next to the alveolus on the right hand side. And this again, because of the variation in texture, is a non-homogeneous leukoplakia. So what's the big deal? Well, this does relate to a risk of development of cancer. If it is a homogeneous lesion, generally speaking, the risks are relatively low, perhaps 1 to 5% in 5 years. There are other features that might dictate that, and we'll come to them in a minute. But if it's non-homogeneous, you have a much higher risk of progression to cancer, perhaps about 20% in 5 years. So what does dictate what the risk might actually be for the individual patient and the individual site and lesion? Well, the site is important, and I'm going to talk a lot about the site and risk of progression and risk of where we get cancers in the mouth. The site is important, and there are high-risk sites which we do need to take into account. These are particularly on the lateral border of tongue, ventral tongue, floor of mouth area, and also on the area which is extending from the retromolar pad up onto the soft palate, the so-called retromolar trigone and the anterior pillar of the tonsils, tonsillar fosses. These are the two main areas where if you have a lesion there, it really needs to be paid close attention to because it has a higher risk of progression. Colour is important. I've made that point already. If it is a uniformly white lesion, that is, it's homogeneous, it has a lesser risk of progression. If it is non-homogeneous, in the various ways that it can be that, it has a higher risk. Texture, variations in thickness of the lesion are important. And then other things that we tend to only find on biopsy. If there is candida present, that is, it's a dysplastic lesion, but it's got some candida in the surface, it's not primarily a candida-based lesion. Well, the presence of candida there is a problem, and these do have a higher risk of progression. And then the presence histologically of dysplasia, which is the disorganization of the tissue which we see in the progress towards cancer. And the degree of dysplasia is important in assessing the risk of progression to squamous carcinoma. What about erythroplakia? Now, as I indicated, the name alone really means it is a red patch or a red plaque. The WHO definition is here you can see. Again, you can't characterize it as anything else, either clinically or histologically. This is much less common than leukoplakia, but you can see from the clinical pictures the type of lesions you might be looking at. There's one on the right side of the dorsum of the tongue, a red lesion, and then on the left side, you can see on the lateral border extending onto the ventral surface of the tongue, a lesion which has got some white striae round about it, but it is predominantly a red and velvety appearing lesion. So the terminology, again, is not necessarily used in every context really consistently. And some people will use terms erosive, or there is obviously an overlap to the speckled lesions of non-homogeneous leukoplakia. There are no good incidence studies which really can be relied upon, but we do know that its incidence, its prevalence rather, is much less than leukoplakia, but its malignant potential is much higher. And in fact, when you biopsy erythroplakic lesion, about 50% of them at that time will either be severe dysplasia or carcinoma in situ. Carcinoma in situ really looks as if it's just on the verge of starting to invade and become a carcinoma. And in fact, in a proportion of them, it will already be a squamous cell carcinoma. So here's an interesting lesion which is present at one of these high-risk sites. You can see we're at the lateral part of the soft palate, which is extending up the tonsillar pillar. And there is a red patch here. I'm sure in looking at this lesion, you might well think, there's quite an extensive differential diagnosis here. Could the patient have traumatized this lesion? Does the patient perhaps have the remnants of an upper respiratory tract infection that's caused some inflammation around the Valder's ring and so on? But in this case, neither was the case. And this had only had smoking related to it. And this, when it was biopsied, was severely dysplastic. This again is a photograph which has come from the WHO collection of photographs related to these lesions. Some people have referred to this as the appearance of strawberry jam spread across the cheek, and you can see it's got that velvety gelatinous type appearance in this lesion, which is extending across most of the buccal mucosa. Here's another lesion. This again is on the lateral part of the soft palate. In the middle in your screen there is the maxillary tuberosity. The tongue is down in the bottom right. And not very well defined, but are a predominantly red lesion. And it is very often the case that lesions in the posterior part on the retromolar trigone onto the soft palate, that is where you're likely to find your erythroplakias. Both of these lesions, leukoplakia or erythroplakia, need to be biopsied. And you get a wide variety of histological appearances from that, all the way through, as you can see from the list here, from hyperkeratosis with no dysplasia, the hyperkeratosis giving the lesion its white appearance clinically, and then the various grades of dysplasia through to carcinoma in situ, and then frank squamous cell carcinoma. And the differential diagnosis of what you might find in histology encompasses really the whole of that. So here is our leukoplakia with keratosis. I said to you I would come back to this whole idea of kind of verrucous type appearance, and you can see that the keratin surface is pulled up into peaks, and that you may see that almost as a sort of rough surface on the lesion clinically, and so that's a lesion which is hyperkeratotic, has got a verrucous surface, but the underlying rest of the epithelium is relatively normal. However, in a proportion of lesions when they're biopsied, we do find epithelial dysplasia. The epithelial dysplasia in itself is not a single thing. It is a collective term that we use when we assess a whole number of different features in the epithelium, and we draw them together to form this kind of composite idea of dysplasia. We grade epithelial dysplasia as mild, moderate, or severe, and that depends on either the severity of the individual features or the extent to which the epithelium is affected by them. There are no hard and fast rules as to how you do this, which means that the process of grading epithelial dysplasia is somewhat subjective, and that is one of its limitations. However, we know that when you get epithelial dysplasia in an epithelium, that in itself does come along with an increased risk of cancer development, and the risk is increased from mild through to moderate to severe. So if you have a severely dysplastic epithelium, you are going to have a higher risk of progression than you would have in a mildly dysplastic lesion. Some people do use the term carcinoma in situ quite widely. I don't tend to very much, but it's there in the literature. You'll find it in the books, and so it means that it's essentially, it looks like it's just about to start to invade, but there is no invasion being found in the biopsy. So there are lists of features that we look at in the epithelium. There are those which relate to the overall architecture of the epithelium. How is the epithelium as a tissue looking? Is it stratifying normally? Are we having a nice progression through from basal to prickle cell and so on? Are the basal cells still lined up as they should be? Are we getting an increase in the basal compartment so that we're getting large drop-shaped retipegs? And then there's the cytological features, and these are the features of the individual cells themselves. So do we have an increased number of mitotic figures, or for example, are they in the wrong place in the epithelium? Do we have varieties in cell shape and size and nuclear shape and size? That's cellular and nuclear pleomorphism. Sometimes the cells look as if the nucleus is more darkly staining than others round about. That it reflects the fact that there is more DNA there, they are hyperchromatic. And so that may well relate to the amount of DNA in a cell. It's perhaps copying its DNA but not being able to divide, a feature that we see sometimes in precancer and cancer. Sometimes the keratinization program gets switched on in individual cells before it should, so that's individual cell keratinization. And even in other cases, the cells begin to lose their adherence to each other, and so the cells are beginning to break apart. So we sometimes see any mixture of these, and we bring them all together as an overall subjective grade of the whole epithelium as mild, moderate, or severe dysplasia. So histologically, this is the sort of thing we might see. For mild dysplasia, generally we say the changes in the epithelium are only in the basal third. So the architectural changes here are quite mild, but you can see cytologically, if you have a look at this picture, there is variety in the shape and the size of the cells, and there also is variety in the staining intensity of some of the nuclei. And so this would give us the assessment overall that this is mildly dysplastic. Moderate dysplasia moves on a stage from that, and the abnormalities extend further through the epithelium, usually into the middle third of the epithelium. In addition to more of the epithelium being involved, the cytological changes tend to be more severe as well. And you can see that there is a greater variation in the extent of the size and shape of the cells. There are some really quite large cells There's a mitotic figure here and so on. But generally speaking, the epithelium is sorting itself out before it gets to keratinizing its surface. The abnormality doesn't extend through the full thickness of the epithelium, so it's moderately dysplastic. And this is severe dysplasia. And here the epithelium is really very abnormal. It's not maturing normally. There are these rather unusual looking cells which are scattered through the middle part of this epithelium with little squiggly lines through the middle of them. These are mitotic figures and they shouldn't be there. And so this epithelium has, in terms of its overall architecture, become very abnormal, and in terms of the individual cellular features, also become very abnormal. And so that's severe dysplasia. So here again we have a number of different epithelia here, and you may well get a chance to have a look at others as well. In the top left, we've got an epithelium that has long reedy pegs in it, but overall the epithelium is maturing quite normally. There is some variation in nuclear shape and size within the basal part of the epithelium only, so this would be mildly dysplastic. Moving next along to the one in the top right, here again you can see the reedy processes, these drop shapes that extend into the underlying connective tissue. And the abnormality in the cells, the variety of shape and size, and the fact that they're not really lined up properly is indicative of dysplasia. And it looks as if the abnormality extends probably into the middle third of the epithelium. This is one which is probably on the boundary of moderate to severe epithelial dysplasia. On the bottom left, in this case, the abnormality extends through almost the full thickness of the epithelium. We don't really have any proper maturation of the epithelium even by the time it gets to the surface, and all these variation in nuclear and cellular shapes and sizes are present all the way through the epithelium, so that would be severely dysplastic. But then we have ones that we find difficult, and that is where our judgment comes into play on these on a day-to-day basis in diagnosing these. This epithelium has got a light layer of keratin on the surface. It's the photograph on the bottom right. It's got long reedy processes, and there's quite a lot of abnormality in the individual cells. So this is a tricky one. I would probably have called this moderately dysplastic, but it's one that even given it to the three pathologists who are in the dental school, you might find there is a little bit of difference of opinion, and that is because the assessment of dysplasia is subjective. Carcinoma in situ is this whole idea of something which is malignant but not invasive, which I find a little bit of a counterintuitive idea, but nonetheless the terminology is used. The epithelium is abnormal through its full thickness with very pronounced cytological features. So what about bringing together the clinical lesions and the histology? Well, leukoplakias vary in the amount that they show dysplasia. In some studies it's 20, or others up to 50% will show dysplasia. But there is a variety in terms of whether the lesion is homogeneous or not. So the non-homogeneous lesions are much lower in terms of the proportion of them that are dysplastic than the non-homogeneous. What is the significance of dysplasia? Well, dysplastic lesions, about a fifth of them will progress to malignancy if left just to develop as they would in their own natural history. A proportion of them will regress, and particularly that's those patients who modify their risk factors. It is possible that lesions in the oral cavity, which precursor lesions, can actually disappear if a patient will modify their risk factors. Many remain unchanged, either in appearance or in size. A proportion of them will continue to increase in size, but not in severity. And these patients who do have ongoing lesions do need to be followed up periodically, and that may well be within secondary or primary care settings. Now, as I indicated earlier, sight is very important. And the risk of progression to cancer within these precursor lesions does vary by site. The high-risk lesions, the ones you need to remember, are the lateral border of the tongue and the floor of mouth. And so that's really a whole area extending from the lateral margins of the tongue round under the ventral surface of the tongue and onto the floor of mouth. And then the retromolar complex, retromolar pad, lateral part of the soft palate, and the tonsillar pillars or the fauces are also very important. Lower risk areas include the gingiva, buccal mucosa, labial mucosa, and the hard palate, and including in that, of course, the dorsum of the tongue as well. But an important point to make is that the risk is present in all areas. There may well be some areas in the mouth of which the risk is higher, but you cannot ignore areas in the mouth because they have negligible risk, because that does not exist as a concept. You need, in your oral examinations, to be looking at all of the soft tissues. So here's a lesion on the lateral border of the tongue. That is a high-risk site. In this case, it looks as if it might be quite a thick lesion, and although it's fairly uniform in colour, on clinical examination, that may well be proven to be a non-homogeneous leukoplakia. Here's another interesting lesion. In fact, it looks as if it's almost ulcerated, and we're going to come back to that as an idea and as a sign of malignancy in one of the later sections. It's on the lateral border of the tongue, and this in fact was a squamous cell carcinoma when it was biopsied. Here's a floor of the mouth in an elderly person. And again, as I indicated earlier, this can be a very challenging area to assess. There's a milky whiteness across quite a large area, but there's also a kind of redness. And if you see there's the classic ebbing tide, you can see the ridges of keratosis. It seems to run across the floor of mouth, and that's quite a classic appearance in many patients who've maybe been long-term smokers. It's a high-risk site and needs careful examination. And then some will progress to cancer. Again, we're at the anterior part of the mouth extending onto the ventral surface of the tongue, and you can see here an exophytic ulcerated lesion, which is quite obviously very concerning, and in fact, as you can imagine, was a squamous cell carcinoma when it was biopsied. Tonsillar pillar, we're in an area which you've seen in previous pictures, and you can see a rather poorly defined red patch here, and this was a severely dysplastic lesion described clinically as erythroplakia. But as I indicated, you do get lesions which progress in other areas. This was a patient who had a long-term lesion on the gingiva. In fact, they had long-term lichen planus, and you can see the development of a carcinoma in this site. So these sites cannot be ignored. Buccal mucosa. The progression of buccal mucosa lesions is very low indeed, but it does happen, and in particular in relation, as you can imagine, to some of the risk factors. For example, if you have a patient who's been using PAN, then you do need to pay very close attention to the lesions on their buccal mucosa. Just as I finish this, I want to bring to you one concept which is really quite important in understanding the natural history of these lesions. And this is the concept of field change. Now you can see a clinically evident lesion, but of course that's not all the abnormality that's present. Patients who have smoked over a long period of time may well have a clinically evident focal lesion, but the likelihood is that there's a much larger proportion of the oral mucosa has been damaged due to the exposure of risk factors. It might not clinically be evident, or it might in some cases not even be evident on a biopsy, but genetically it is there. And so this field change refers to a field, a larger area of common genetic abnormalities. This is epithelium that has been primed, if you like, by the exposure to risk factors. And so that means although you've got a very focal lesion, the whole of the rest of that affected epithelium is at risk. So for example, if you were to say you had a lesion like this on the floor of mouth, let's say it's a white patch, if you were to take a whole load of biopsies and map out maybe where the dysplasia extended to, it's maybe a bit bigger. So not everything is going to be clinically evident. But if you were to, by various genetic means, map out where the genetically abnormal epithelium was, you may well find that it's much larger. And this is a particular problem in relation to how we then approach treating these lesions. Do we just remove the clinically evident lesion? Well, that will leave behind a large field of genetically abnormal epithelium. But of course, it's not necessarily possible to remove that large field of genetically evident epithelium, because that can extend many centimeters away from a clinically evident lesion. So this brings us to this concept, which is here in a diagram which has come from a recent Nature Reviews in Cancer paper about head and neck cancer. And you can see in the center here that you have the light blue dysplasia giving rise to a carcinoma. On the right side, if you get all the dysplasia out, well, anything that happens is a completely separate tumor. But on the left-hand side, if you leave behind some of this primed epithelium, well, then you can get the development of second field cancers. And unfortunately, about 20% of patients who have head and neck cancer develop a second cancer, and that can be anywhere from the mouth, the pharynx, the larynx, and into the lungs. Here's an example of some field change cancers. A patient, a lesion on the anterior part of the maxillary alveolus, way back 1980. It was removed. It's repaired as a skin flap, as you can see with the hairs on that. Looks, or maybe a little bit scruffy looking in 1994. And then you see here a patient who then presents back in 1989, and there's actually a lesion within the skin flap. But also there's a lesion in the other area, and this is down in the mandibular alveolus. Again, you can see a rather ugly looking non-homogeneous lesion, which is quite concerning. Patient was lost to follow-up. The progression in the lesion on the alveolus back a number of years later is to a frank carcinoma, and there also was a development of recurrent, a new other carcinoma in the skin flap at that same time. So this patient had an overall abnormality in the epithelial, in the oral environment. They had not stopped smoking, and so that contributes to that process ongoing. So that's all I want to talk about, particularly about leukoplakia and erythroplakia, and we'll move on in the next section to have a look at some of these systemic conditions which also predispose to oral cancer.